Take Back Your Health Now, Episode 107. Information contained in this podcast is not medical advice. It is for educational and informational purposes only. Please consult with your doctor before making any health choices.
You're listening to the Take Back Your Health Now podcast, the show that interviews the top doctors, athletes, trainers, and entrepreneurs to help you find the holy grail of health. Now here's your host, Dr. Dan Margolin.
Hi, this is Dr. Dan Margolin with another segment of Take Back Your Health Now, where we pull out all the stops in search of health's holy grail. Today we have Dr. Watson. He is a clinical director and owner of Associated Psychological Health Services. In 2005, he started it's a local outpatient clinic operating for nearly 20 years. He added the R.E.A.Ch V.I.P program, Recovery of Emotionally Abused Children with Volunteers in Psychotherapy, modeled by the late Dr. Kevin McCready and Richard Schulman, Ph.D., whereby those without any financial support could obtain free clinical services for volunteering their time in the nonprofit local community. Dr. Watson has provided testimony to the Food and Drug Administration regarding ECT, which is electroshock therapy, and SSRI, induced suicide. Those are the psychiatric medications. He was an invited guest speaker and lecturer to the Congress of Mexico, speaking upon children's mental health and the possible link between psychiatric medications and violence. He has appeared on several national television shows, Oprah, Family Network, etc., speaking about child behavioral disorders being treated by psychological intervention as a first line of defense as opposed to psychiatric medications. And he has appeared as a featured guest on numerous radio shows throughout the United States. Dr. Watson, we've interviewed you before. Welcome back to the show, sir.
Hey, thank you, Dr. Dan. Pleasure to be here.
Let's sort of jump right in. I know you were actually asked to speak to the Senate of Mexico on children's mental health and ECT, I guess SSRI, drugs and stuff like that. Could you just go over with us, if you would, why you were asked to speak there and what you spoke about, sir?
Well, about 2 years ago, one of the congresswomen of Mexico started to notice that in the United States, we have a lot of mass shootings, and there were reports that these people were all taking psychiatric medications known to cause, violence, aggression, suicidal ideation, and suicide behaviors. So she was smart enough to say, is there a link? Is this what's causing some of these people to do it? And in Mexico, they had just had a similar incident, and it was, I think, one of the first of its kind. And they were looking at increasing mental health funding for children. And so they said, hey, we'd like to find out if there's some research out there or some people out there that know about this, and talk to the Congress. So they ultimately invited me down and found me through an attorney out in Los Angeles. I went down and gave that research and that talk about 2 years ago. Well, fast forward now, the Senate is looking to write and pass new legislation to have some safeguards in place for their mental health interventions, i.e. psychiatric medication. So they invited me down again now to give this lecture over 2 days at kind of a mini conference, and it was nationally televised. And so I went down there and met with the senator that invited me and did this presentation talking specifically about this information.
Now, Dr. Watson, let me ask you, I've known probably for 20 years that these psychiatric medications, I forget the exact numbers, but I'm pulling this out of my hat a little bit, but I said there's almost a natural suicide rate among people of, let's say, maybe 3 in 10,000, right? Whether they're on medications or not, just in the course of the pressures of life, something like that. On these medications, I was aware that those numbers jumped dramatically into the close to the 100 mark. Now, again, I might be off on those numbers, but it was such a dramatic jump. And I was aware of this 20 years ago. Is this like now an awakening of the public because it's becoming so obvious? Like what is prompting people to actually start to look at this?
Well, I think part of the reason that the general public is recognizing it is that, one, we've added these black box warning labels to the antidepressants or a certain category of antidepressants. So hopefully doctors are informing patients when they suggest taking like Prozac or Paxil or Effexor, that they're letting them know that, hey, this is the most serious and stringent warning label you can put on a medication, which is saying if you take this medication, you could become more aggressive, you could become irritable, you may increase your thoughts of suicide. And the FDA said that there's a causal link to it. That's the reason they put those warning labels on there, is that it's not just by the normal feature of depression that some people get suicidal. This is actually causal, saying the medications will cause you to become suicidal. And I think that's one reason why people in the public are learning this. And then also there's researchers like me that go on radio shows like you, informing them, so that people really are getting the information.
Wonderful, wonderful. So I did cut you off a little. So you get to Mexico, you get in front of the Senate. Give us a summary of what you spoke about.
So what I highlighted is that basically, in the United States, we have half the mental disorder rate that Mexico does. We spend the highest amount of mental health and drug intervention on the planet, over $200 billion. We have the second highest income level for children worldwide, meaning that we have more money to use for our children. And yet our incidence of suicide, homicide, aggression and violence, and mass shootings is vastly higher than the country of Mexico. So we have 400% higher suicide rate for men than they do in Mexico. We have over double the rate for our kids, and yet we have 6 times the amount of income that we spend for kids than in Mexico. So I kind of highlighted that, well, if we're doing such a great job, why did UNICEF rank us second to last out of like 30 countries in the world for children's well-being and mental health? So we're not doing a good job here, and yet we're spending, bar none, more than any other country on the planet. Right now, 1 in 4 or 1 in 5 people in the United States takes at least one psychiatric medication. And unfortunately,
so the medicine, Dr. Watson, so the medicine the money that we're spending is actually going into the medication. Is that where the money's going?
Correct. That's exactly right. The money is being spent vastly on hospitalization and medication, what we call kind of biopsychiatric intervention. And the problem is that by setting this type of system up, where we go from early intervention screening, which sounds good, like, oh, you got to screen early, they get screened at school, they get screened at their pediatrician's office, they get screened at their dental office, they get screened over and over again. It's almost impossible for a child to go from 0 to 18 without getting caught in the fishing net of psychiatry and psychology, trying to get them in for some reason. And we know from research that if a child goes into a medical office, general practitioner, for any reason, just any reason at all, 10% are walking out with a medication, and out of that 10% that get a psychiatric medication, 25 don't even have a mental disorder diagnosed. They're just getting it anyway. And in general, right now, 1 in 4 or 1 in 5 people in the United States is taking at least one psychiatric med. And in 2006, they just did a study where they showed that actually they're not even getting one medication, but upwards of like 60% are getting 2 meds, and 33% are getting 3 psychiatric meds when they come into the office.
Can I just to tell you a little story? We have a close family friends that they have about, I think they have 4 children, and all of those children had been diagnosed with ADD and other disorders. Okay? And they adopted a young girl who, this is several years ago, who's about 4 years old, and immediately took that adopted child to their family psychologist or psychiatrist. And that child, again adopted, was immediately diagnosed with ADHD and put on medicines like Ritalin and stuff. And I said at the time, we had a big fight because I said, look, this doesn't make any sense. Okay, you're telling me that there's a family predisposition to this thing, and that's why everybody in your family is on these meds. But then you adopt some child, and the chances that this child would have the exact same disorder. Anyway, 4 years or 5 years later, the child's been on these medicines and is getting progressively worse, and has now been diagnosed with a more extreme diagnosis, if you would, and they're considering putting her on much stronger medications and stuff. And I saw this child 4 years. There's a beautiful young girl. There was no, I mean, I'm a podiatrist, so take it for that. But I know what a child looks like. I know what a happy child is. And now you see 4 years later, this is not the same child. This is not. It just, to me, is not making any sense. So maybe could you clarify that for me a little bit? Is that something I'm not observing, or I am observing, or what's your thoughts on that?
Back in 1952 is when the book that we use in psychiatry and psychology came out, called the DSM, Diagnostical Statistical Manual of Mental Disorders. And it had, a few dozen labels that we could diagnose people with, which again are just descriptions of thoughts and feelings and behaviors. There's no actual pathology. There's no brain scan. There's no chemical imbalance. There's no biological test for any psychiatric disorder that you could ever use to diagnose somebody. But now fast forward today, we have over 700 subtypes and diagnoses in that book, and it is a massive book. But keep in mind, a colleague of mine, Dr. Alan Francis, who actually was the chairperson of the last book that just came out, the DSM-4, he's even come out now and indicated, quote, vastly, these mental diagnoses are being overused to describe mild problems of everyday life, which are better described with just normal language. He's acknowledged that we've gotten out of control with, labeling and diagnosing normal type behaviors. The NIMH, which is the National Institute of Mental Health, Dr. Insel, who's in charge of that. This is the largest funding agency for research in the world. They just this past year came out and said that DSM is best, quote unquote, a dictionary, and that they're going to stop using it for any of their funding because it lacks validity and they have no objective laboratory measures for it. So we know that this.
Well, my understanding is that, like, when they come up with a diagnosis, right, there's no laboratory objective measures. Basically, they vote it in. So, and there's some financial advantage to them to have as many diagnoses as possible. So it would make sense to me that you would vote in as much money as you could potentially make.
Correct. Right? And these people who voted in, who are all on this DSM panel, this, they say, hey, we're going to make up a new disorder and just create it. They all have financial ties. Almost 100% of them had financial ties or do have some sort of funding from drug companies. So they're benefiting, from the new disorders and new illnesses that they're just magically creating. And the problem is that
Dr. What you may not be able to answer this, but what a child that is started on these medications, and they're doing it now as young as 4, like I said, 5, 6, over the course of their lifetime, what is that like? What are we talking about in terms of finances?
Well, you're talking about literally over a lifetime, with the amount of people in the United States being diagnosed, labeled, and then medically treated. You're talking about hundreds of, millions of dollars. In fact, billions of dollars. The psychiatric industry is making, greater than $10 billion, I want to say, in sales. I forget the exact numbers, each year. I know, like, for Zyprexa just a few years ago, which is was only supposed to be used for like severe, like, psychosis, what we call schizophrenia, or label as, something like that. Yet that was one of the number one selling drugs, and they were over $4 billion in sales for that 1 year. But yet they're giving it to young little, infants even, and children, which is, I think, abuse.
What's the youngest you've seen it?
The youngest that I personally in my clinic have heard, and I didn't even see the child, was 3. But yet I know there was a report that came out not too long ago. This was going back about a year and a half ago, that specifically looked at the rates that young children and infants were being given. And we saw that even infants, coming out of the womb, were being given psychiatric meds. There's 10,000 toddlers, which is, again, younger than that 3-year-old or at 3-year-old, being given ADHD drugs. There were from zero to 1-year-olds. There were 370,000 overall being given psychiatric drugs. So we're talking about crazy numbers.
Doctor, just to play devil's advocate, is there any possible way in hell that you could figure out that a 1-year-old who would have ADHD or any kind of these diseases? I mean, what kind of an objective measure could you possibly use to actually do that and then put this child on medication? I mean, should we just arrest these people right now, or what?
Well,
I mean,
and I did. I was really concerned about it because the big one was the anti-anxiety, like, these Ativan or Xanax, this major epidemic of, these Xanax-type addictive drugs. There was 250,000 0 to 1-year-olds being given those drugs. And I thought about it, and I started talking to some researchers and MDs, and the thing that they said is that the parents are so addicted to it, and they're pregnant. So they're taking these while pregnant, and then that means the infant is now addicted to it. So they don't want the infant to go through a withdrawal reaction, a discontinuation syndrome, which can be extremely dangerous when people stop taking these meds. Same with a child. So they literally have to keep the baby on the med for a while or forever, according to some, because they're afraid if they take it away that they'll go through some sort of horrible withdrawal reaction.
Now, Dr. Watson, I'm a podiatrist, right? And on pregnant women, I will do no surgery unless maybe if they have an infected, let's say an ingrown toenail. And then we give like lidocaine, which is essentially Novocaine. We don't do that unless we actually speak with their medical doctor. So we're very cautious about any medicine we would give to a pregnant woman with the concept that we just don't want to in any way hurt the child. Is it strange that you would not take someone that is pregnant off of those medications? I mean, while they're going through the pregnancy, with this concept of, hey, let's protect the baby.
Well, that's again, each practitioner is different in their ideology. Unfortunately, in today's culture, there's so many studies that are showing how much harm there is to an infant or a developing fetus, but yet practitioners are not, I guess, getting that information or understanding it or seeing that it's serious. So they're just allowing, pregnant mothers to continue to take a lot of these medications out of fear that if they take them off, that there'll be either a discontinuation syndrome happening or that the pregnant mother will go back into whatever, problematic thought or feeling or behavior she had before she got on the meds, which I think really goes to the major issue here is that this is simply a Band-Aid suppressing a thought, a feeling, or behavior. And a drug is a drug, psychiatric or illegal. It will have an effect, and it might be desirable, but it's going to come with a price, and you're not doing treatment. Treatment is where you really help the person figure out why they're having these problematic thoughts and feelings and behaviors, whether it be nutritional or whether it be, activity of life issue that they're dealing with, or whether there's some sort of mental, kind of trauma or old history or skill deficit. But you've got to take the time to really find out what is going on for the person. Simply covering it up, suppressing it, through a pharmacological agent like a drug. Again, all you're going to do is suppress it. It's going to end up getting worse. And then when you try to come off the medication, you're going to even be worse off than when you started.
Dr. Is there any, I guess, literature, whatever, saying, comparatively speaking, let's take happiness level of a patient, where a patient that's been on medication versus a patient that's doing what you just said, where they go through some sort of a counseling, where they're actually addressing the actual issues that started them on the drugs, where there's some sort of a nutritional situation addressed, a comparative thing of who is happier at the end of the day?
I don't know off the top of my head a specific study that looked at happiness levels with regards to pregnancy.
I'm using that. I'm sort of making. I don't know what you would actually say, but just any kind of study that would indicate that people that are just really addressing the issues are doing better than people that are actually on the medication.
Oh, sure. I mean, there's numerous studies out there that have shown that, people who take, like, for example, one of the 12 most widely used antidepressants, R.E.A.Ch did a wonderful job talking to the FDA about this, that one, we know these medications really are just placebo effect, that yes, you'll feel a little happier when you first start taking them, but it really isn't because of the drug. Because if I gave you a sugar pill, I could replicate that happiness increase in about 90% of the people who are taking the sugar pill, meaning that there's no difference clinically between taking the sugar pill and taking an actual antidepressant. However, what we do find later is that the people who are taking the antidepressant have anywhere from a 200% increase all the way to 700%, sevenfold increase in becoming suicidal and committing suicides. And the benefit of, quote unquote, that medication doesn't last longer than 16 weeks, meaning that people that get into therapy or find out some other way of helping themselves feel better ultimately feel a lot better, report better feelings over the long term. So again, the idea of the meds were, let's give them something that will give them a quick jolt to feel better, but they were never intended originally to be something that you stay on. I mean, think about that. The FDA doesn't, and the clinical trials don't last longer than 16 weeks. That's, maybe 3.5 months, but yet people are being told they should be on it for life.
Oh, okay. Wow. Now, when you take these findings and you show them to the Senate of Mexico, what's their reaction? What's their reaction to this?
Well, I had people clap. I had people kind of cheer. I had people come up to me afterwards. The senator, during the recommendations, when I was going through specific recommendations that the government of Mexico could take to, have some safeguards in place, had come down and, obviously he was seated right next to me and, took those and, acknowledged to, her constituents throughout Mexico, saying that she was going to implement these, that she was going to find a way to get others on board with it, to try to pass legislation to do this, that they don't want to have the same problems that we're having here in America, where it really is about profit over people. And so they were very elated and very happy. In fact, they have another kind of smaller conference at the state level in Monterey that they want me to come back again and again let them know about this to see what they can do on a more local level.
Dr. Watson, I mean, this takes a certain courage level to go up against a billion-dollar or multi-billion-dollar industry. Where do you find that courage from? Why are you doing this?
The people that I look forward, I should say, or look up to, are others that have either been whistleblowers or people who have made an effect and a change. Jim Gottstein, who has a nonprofit called Psychrights.org. He, again, was one of these guys who was involved in a case, got information about Zyprexa causing people to die prematurely. And the company hid it. The company lied and hid it. That was Eli Lilly. And so what ultimately happened was he was told by a judge he could not release those papers, and Jim said, that is basically illegal. You're not allowing me to release something that I know could save people's lives. And this company literally knew that people might die and it would be an increase in dying. So Jim went against the judge's orders, released the information to the New York Times, and immediately as a result of that, people started suing Eli Lilly because they had parents and elderly people who were put on the med and died because of the medication. Last I checked,
Wow.
Eli Lilly settled, I think it was about $1.1 billion in lawsuits because of Jim Gottstein releasing those papers. So when I think about the heat that I've taken, and I've taken some heat from federal judges, I've taken heat from local Mental Health America, I've taken heat from psychiatrists, so I've gotten my fair share of heat and threat of lawsuits. But when I see the effect that it has, when I see someone like Jim who risked everything to help other people, to me that's a humanitarian effort. And that's what, again, I got in this business not to be liked, not to go along with the good old boys club. I got in this business to help people and to make the world a better place. And if that means I got to take some heat, again, I'm willing to do that. And again, we all have to kind of do that and speak out when we see something happening that is an injustice.
Well, I mean, the world actually is made better by people like yourself that are willing to do that. Like, what was the first time, like when you first got into psychiatry, psychology, and you first went, I'm assuming that you were somewhat naive to this, right? And then there must have been an awakening. Can you tell us a little bit about that?
Sure. So the first time, I guess that originally I was a neuro student, neuropsychology. It's kind of was the interest I had when I went off to graduate school out in California. And then at that point, I started working at a clinic that was run by Dr. McCready that treated people that had, mental quote unquote disorders or issues going on without psychiatric meds. And these were people that were severely depressed and suicidal, diagnosed schizophrenic or diagnosed or labeled, with bipolar. And then, in my world, you couldn't treat, you couldn't help people like that. It was, hey, you had to be on meds lifelong. And I saw people get better. And I was like, wait a minute, that doesn't match what I've been told. And then I started seeing more research and learning more about this, I guess, whole other world of research like that. Hey, it's not true. And that's when I made the shift. And I said, wait a minute. And I've come full circle now, going from the belief that meds are mandatory and necessary to these things clearly can, have a short-term effect on people for the positive if they're just trying to suppress something. But absolutely, over the long term, these medications are devastating. And frankly, they're actually killing people and shortening the lifespan of.
Do you find that most psychiatrists, most psychologists are actually putting people on these meds because they're not educated about this, because they're actually being walled off from this type of knowledge, or they are aware of it? Like, what's your feeling on that?
I think several things are happening. One, we're one of the only countries in the world that allows drug companies to directly market to the consumer. So, that happened with Bush Sr. back in the day, where he was on the board of Eli Lilly and thought it would be a good idea to let Eli Lilly just market right to the consumer, and it did.
Oh, really?
Thousands.
No. When was that? When was that?
Well, Bush Sr. was the president. What was that, going back probably 20 years now, I guess.
Wow. Okay.
So one, that was a huge benefit, the biggest benefit to drug companies in America without question. And again, we're the only country basically on the planet that allows that because, we've sold out, to the almighty dollar. But that was a huge benefit where people would go into the doctor's office and say, I want this med. And they would go shopping. If they can't get it from this doctor, they'll go to another doctor and get it. So that was one reason why doctors just started prescribing, I think, more than what I would say would be reasonable. The other reason is that doctors were targeted by drug companies by marketing. Again, they have people who are specifically earmarked to go to that doctor week after week and give them very specific information to try to indoctrinate them, not educate, indoctrinate them to use their medicine and their drug. In addition to that, I think that the research, 90+% is funded by drug companies and or earmarked at a university specifically for their research. So the research that gets published, again, is being tainted. If I'm a researcher and I don't have good results for a drug company, they don't use me anymore. So they start to weed out the people who are not sympathetic to the cause or who are really good and ethical. And so we start to have, again, only data that supports the drug use. Because again, if I have a study that shows it didn't work, that doesn't get published. I can't even get that into a journal a lot of times. There's no journal of negative studies. In fact, they've talked about this in the studies or in the research, like, where does all the negative stuff go? It doesn't get put out there. So you get skewed information and only see the stuff that says, oh, this is wonderful. For example, if you go to Google right now and type in most effective treatment for depression, what are you going to see? It's going to be flooded with study after study after study that shows medications are beneficial. Why? Because if I fund 1,000 studies that show medications are beneficial and the ones that are negative don't get published, they don't get onto Google. And there's nobody that has money that is funding the researchers to say, hey, this didn't work. Or, hey, let's look at, these other types of, like nutrition and exercise and all these other things that people can do. That's not financially beneficial to people.
Or, I think it's funny. It's interesting that you also said that they were indoctrinated. And I know when I've spoken with psychologists, psychiatrists, and I have, regarding this, they get offended. They get very emotional, like they're not listening. And it is more of an indoctrination. In other words, rather than say, hey, let's look at another perspective and show me some studies, at least some of them that I've come across, we're not particularly open to that. And it is more of an indoctrination than, you would think that somebody in that field, as I am in this field, I'm looking for answers, right? I'm a podiatrist, but I'm always trying to figure out a better way to do something. And I think that's the correct approach. As a doctor, you should look at things and say, good, is there a better way? Like, what's evolving? What's the newest literature? Which would really open you to research and actually looking at different things. I don't see that so much. And maybe that's just the people that I've spoken with. But overall, is that what you're saying?
Yeah, I think that's one of the problems is that when a lot of psychiatrists, and keep in mind that 90+% of all psychiatric meds are not written by psychiatrists. We kind of beat them up, but really it's general practitioners. That's who's writing all these meds.
Wow, I didn't know that.
The problem is that general practitioners get about 30 hours on average of training in psychiatric psychopharmacology. That was a study that was done by NAPPP, which is an organization of psychologists, second largest in the world. So really, the vast majority of the people out there are getting their meds from a doctor that had a long weekend of training in psychiatric psychopharmacology. And the problem is that imagine a doctor who's been doing this for, let's say, 5 years, 10 years, 20 years, or 30 years, and they think they're helping people. And then some, young punk kid like myself, although I guess I'm not that young, comes along without a medical license who, is a researcher who says, hey, by the way, according to the research, these meds are actually causing people to become more chronically ill because of the med and what's happening to the brain. And they're starting to become more suicidal, more aggressive, and you're actually making these people worse in the long term. Now, that doctor has two choices on what they can do with what information is being given: accommodate it or assimilate it. Either they have to change their thoughts and change their neurology and say, maybe I've really messed people up, and maybe, oh my God, I've done this horrible thing, and oh my God, I didn't know. Or they can change the information, say, this guy's a whack. This guy's got to be, some weird, researcher. And they dismiss the research and they try to discredit me rather than a look at the possibility that they have a faith. And it is a faith because, again, the research is on our side saying this is what happens to people when they stay on the medication. There's no questioning that anymore. I go to court all the time for people all over the country, and I present this data. I've never been discredited, never had my testimony excluded or the data excluded. The psychiatrists come in and they give their opinion. It's a faith-based opinion because of what they see and what they believe versus this is what the research is saying is happening to people. And I think that's important for people to realize when they get prescribed or somebody says, hey, I want you to go on this, the questions they should be asking that doctor is, you say I have a chemical imbalance. What chemical's out of balance? How did you measure that chemical? Where in my brain did you take or measure it? And what is the correct balance? Because they don't have any data to support any of that.
Unbelievable. You're blowing me away, Dr. Watson. Thank you. That's I don't know. This is such an amazing interview. I'm just blown away. I mean, what for somebody listening to this that has never heard this kind of information before, I could see that it's shocking. I could see where they'd go, no, that's just a crazy program I listened to, and but they'd almost want to like sort of push it to the side. But this information's got to get out there. It's very, very important, and just because it hasn't gone particularly mainstream yet doesn't mean it's not correct. I think it's very correct. Our show is looking for the holy grail of health. I mean, that's really the whole concept. So I'm going to pose the question to you regarding this whole area of mental health, if you would. If we were searching for the holy grail of health, what would that be, sir?
Well, to me, when people are suffering, there's always a meaningful reason for their suffering. Now, it could be, yes, we do recognize that there are nutritional deficiencies, or recognize that we have hormonal type things. Again, those are medical things that need to be dealt with, or nutritional. When we're talking about emotional suffering, the Holy Grail, again, is simple. When we suffer an injury to our humanity, the only thing that's going to restore our humanity is humanity, love, empathy, compassion, play, laughter, all of the artistic expression of humans, like, art and dance and music, and all those things that define us as human beings, that compassion, being together, that's what's ultimately going to restore one's humanity. And sometimes that just takes time and a lot of patience and a lot of, caring and understanding. And so I think when people are hurting, they need to find that person that can help them restore their humanity. Everything else is kind of a medical illusion of trying to suppress humanity. If I give a medication to try to make someone's sadness go away, I'm cutting off that part of their humanity. And it's not surprising they do more inhumane things. So I want to amplify that sadness. I want to amplify that, psychosis. I want to amplify their anxiety. I want to create new meaning for it. And I want to explore that, and I want to talk about it and not be scared of it. And when people do that, you don't see these horrible acts of aggression. You don't see people committing suicide. If they're talking about suicide, they're not acting their feelings out. When somebody stops talking about it and it's suppressed, that is when I get scared.
Wow, Dr. Toby Watson, what a powerful, powerful interview. I want to thank you for your hard work. I want to thank you for standing up for the little guy, if you would, and your life's work. It's greatly, greatly appreciated.
Well, thank you so much. I appreciate that, Dr. Dan, and thank you for having the show and the platform to let your audience, I guess, get educated and think about this a little more critically.
No, I think it's important. Dr. Watson, how would people that want to get in touch with you or find out more about you, how would they do that?
Yeah, I'm easy to find. If people just type in Dr. Toby Watson in Google, they will ultimately find me on my website, and I'm easy to get a hold of.
Dr. Toby Watson, thank you for a wonderful interview, sir.
Wonderful. Thank you so much.
This episode is sponsored by New Jersey Foot and Ankle Center in Oradell, New Jersey. Remember, when you have a foot problem, you've got a foot doctor in the family. Weekend and evening appointments are available. Call us at 201-261-9445. Once again, that's 201-261-9445. Thanks for listening. Check out the show notes over at drdanspeaks.com. If you're loving the show, head over to iTunes and leave us a review, and we'll catch you next time.